Hello everyone, welcome to Dr. Royce. Here I am with a video over GBS, also known as Guillain-Barre syndrome. So recently Pune has witnessed a significant surge in GBS cases with over 100 reported, and there is the first fatality suspected. So this is an alarming outbreak, underscores the critical importance for every medical professional to understand GBS thoroughly. So here in this video, we will delve into the essentials from clinical features to pathophysiology to key diagnostic clues and high-yielding management strategies, which will not only help you to recognize the case but also will help you to handle GBS with confidence. So yeah, let's dive into the video. So before beginning with the video, I want to tell you that this whole video and the content is from Harrison's 21st edition, the latest one, so you could really rely on this information. And also Guillain-Barre syndrome is going to give you 1 or 2 MCQs in your competitive exams. So let's begin with the video. What do you think when you hear of Guillain-Barre syndrome? What exactly is Guillain-Barre syndrome? So let me write it down. Guillain-Barre syndrome is actually an acute condition with fulminant polyradiculoneuropathy. Also, it is believed that it is an autoimmune condition, which we will see into pathophysiology in detail. Let's first write down the clinical features. It will help you with an overview like what you're looking for in Guillain-Barre syndrome. So here are the clinical features. It's a rapidly involving reflexic motor paralysis with or without sensory disturbances. But here comes the point, like in most of the cases of Guillain-Barre syndrome, they are with some sort of sensory disturbances. We'll see in the further that it is a rapidly evolving reflexive motor paralysis, which is also ascending in nature. So what do we understand by ascending? So just imagine this is a person. Sorry for the diagram. Let's say these are his limbs. This is chest with lungs. Okay. Yeah. So it's an ascending paralysis. That means that it is going to begin with some distal paresthesias involving the lower limbs first, and then later it is going to progress to the hips and then to the upper body, and soon it will involve the chest area and then to the arms, neck, and then to the lower nerves, the bulbar and the facial nerves. We'll see the manifestations very nicely the next part. So this is ascending paralysis. Also, it's an acute condition. So what do we mean by acute condition? Basically, it could progress to full-fledged symptoms over 12 hours to 28 days. So the whole disease is going to progress within a month, which is like really fast. But recently we had heard of that in Pune, the condition is spreading, evolving so fast, like within 3 days we can see patients with symptoms. So according to the literatures, it could be in the range of 12 hours to 28 days. So I told you that it's going to progress, and while progressing it could involve your lungs, your chest, and the arms part. So also it could go to your brain, the facial and the bulbar weakness. So what do we mean by facial and bulbar? Facial features are like very self-explanatory. You would see the face, something like Bell's palsy. Yeah. And in the bulbar weakness, we know bulbar weakness includes the nerves like 9th, 10th, and 12th nerves. So these nerves are going to present with breathing difficulties. Not exactly breathing difficulties, but due to the involvement, due to this involvement, there would be constant dripping of saliva and secretions out of the mouth patient can't even maintain the patent airway, so that all indirectly or directly affects the patient's airway. Also here we see that the DTRs are decreased to completely absent. DTRs are deep tendon reflexes. I hope you know all this, so I have written it in short forms. So that these reflexes are going to diminish initially, and later when they progresses to the plateau phase, then they are completely absent. And yeah, this is like very important because there is no bladder involvement. Okay, if a patient comes with some bladder involvement, then we should suspect some other conditions, because Guillain-Barre syndrome doesn't involve bladder. And also it is going to involve autonomic involvement. What do we mean by autonomic involvement? The autonomic involvement could lead to manifestations like loss of vasomotor control, leading to fluctuations in BP. Also could lead to postural hypotension, cardiac dysarrhythmias, so autonomic involvement is something which would be seen in even mild cases of GBS. So these are the clinical features, the very basic. So I want to also write about the DDs for ascending paralysis. We talked about it, right? What is ascending paralysis? It is going to involve the limbs, lower limbs, dysthesias, paresthesias, and later they are going to worsen, and then they are going to go to the upper body. So what are the other conditions where we would see ascending paralysis? So conditions like polio, transverse myelitis. So this is very important because you could be asked this questions in your vivas too. GBS, we are studying GBS, Guillain-Barre syndrome, and also in rare scenarios like in rabies. And yes, this one is important. Let me erase this man. I don't think he's helping us in any way. Yeah. So also hyperkalemic, it is potassium increased. Yeah, kalemic periodic paralysis. This is a electrolyte imbalance, and the rest one are neuropathies and neuromuscular involvement like polio and everything. So these are the DDs for ascending paralysis. If you want to add something, then I could say, I won't write it down, but it's just for general thing. This ascending paralysis could be symmetrical or asymmetrical. Okay, symmetrical means it is going to involve both the legs similarly in the same way, okay, at the same time. So our GBS is symmetrical. Okay, it's a good thing, right? It's a symmetrical one. The another symmetrical one is transverse myelitis. So these both are going to show symmetrical ascending paralysis, whereas our polio, it's not good. It is going to show a symmetrical one. And also you could differentiate it on this basis, but when you ask to differentiate, how you're going to differentiate among these two options, transverse myelitis and GBS. So GBS is progressing, it is going to evolve, okay, but in transverse myelitis you would look for the level where it is involved, and below that particular sensory level, all the sensations are gone, and above that the body is pretty normal. But in GBS it is going to involve to till your chest, spines and arms. So these are the ways how you are going to differentiate these three conditions. Basically your Viva examiner is going to ask you about this three only, but if he is going to ask you about some electrolyte imbalance causing the similar scenario, you could answer this as hyperkalemic periodic paralysis, and this is going to give a good impression of yours in your Viva. So yeah, if you can, then you should remember this with this electrolyte imbalance too. So now the next part is antecedent events, like the causes for this kind of disease. Yeah, So antecedent causes are like some sort of infections, mostly in 70 to 80% of cases. Guillain-Barre syndrome is basically an autoimmune condition. So this autoimmune conditions are triggered by some infections. It could be GI conditions or some respiratory conditions. We have a great example of GI condition, which is by Campylobacter jejuni. So this picture over here, you could see, I can't exactly tell if you can visualize it, but this is Campylobacter jejuni. It is somehow S-shaped, curved bacillus with a polar flagella. You could see this is the bacillus with a polar flagella. So this is how you identify Campylobacter jejuni if there is a picture based, image based question. And Campylobacter jejuni, we all know that Campylobacter jejuni is going to cause bloody diarrhea, mainly in children's or young adult. So this is Campylobacter jejuni. We have this great image from first aid, and also this chart which could help you memorize all your gram negative bacteria, So we know this Coccobacillus, most important, Haemophilus and Bordetella pertussis. These two examples are like much more important. Let me erase this. I wanted to visualize the chart. So yeah, this is Coccobacillus. The two great examples are Haemophilus influenza. Okay, and then the next is Bordetella pertussis. And we have diplococci. These are all gram negative. Okay, so we have diplococci. When you see two coccus, gram negative coccus on a slide, then you would suspect two bacteria only, which is gonorrhea or meningitis. They are both Neisseria gonorrhea and Neisseria meningitis. So how you're going to differentiate it? Both are aerobic, so to differentiate it from each other, you would see meningitis. Okay, meningitis have a M. Okay, has a M, so it is going to ferment maltose. Okay, here certain maltose fermentation is seen in meningitis, whereas gonorrhea doesn't have a M, so it is not going to ferment maltose. But gonorrhea has a G, right? So gonorrhea is going to ferment glucose, whereas meningitis is going to ferment maltose along with glucose too. So glucose is not helping you to differentiate it anyway, so they haven't mentioned glucose, but this both aerobic diplococci are going to ferment glucose too. Well, I'm going a bit off topic, but we could revise one more thing, right, in a video. We could make it like it is good for retention. Then we go to the bacilli part. Of course, the gram negative bacilli we could differentiate on the basis of lactose fermenter. We can use agars like McConkey agar to differentiate it, whether it's lactose fermenting or not. So if it is a lactose fermenting, then we go for whether it's a fast one or slow one. Fast one examples are like very favorite: E. coli, Klebsiella, and Enterobacter. Remember, it's Enterobacter, not Enterococci. So there is a great difference. You would get to know that. And the slow lactose fermenters are Citrobacter and Serratia. I think you guys know this because this is very basic. The non-lactose fermenting bacilli are differentiated on the basis of oxidase. If they are oxidase positive, we have Pseudomonas and Burkholderia. They both are going to cause respiratory problems, These are going to cause green, mucus, Pseudomonas, and green colonies too. And Burkholderia is also going to cause respiratory conditions. These both are going to be associated with cystic fibrosis. If you study, then you would see cystic fibrosis causes lung involvement, and the most common organism in them is Pseudomonas, whereas Burkholderia is the most common in organism for adults. It's a bit off topic, let me. Oxidase negative are then differentiated on the basis of H2S production on TSI agar. If it is going to produce H2S, then it is Salmonella proteus. If not, then it's Shigella aeruginosa. Let's go to curved rot, the topic of concern. So curved rots are like basically oxidase positive. If it grows in 42 degrees Celsius, which is like quite hot, so we go camping in hot summers, This is a mnemonic given by first aid. So hot summer, at 42 degrees Celsius. It's our favorite Campylobacter jejuni. So this is our S-shaped bacteria, gram-negative bacteria, sorry. You see it, and there's its polar flagella. So you have to remember this about Campylobacter jejuni. I have linked the micro part also with this. Hope it helps. And the another bacteria which grows in the another bacteria you could differentiate on growing in the alkaline medium, it's Vibrio cholera. It's going to have a unipolar flagella, curved shaped bacteria, but it is going to cause diarrhea, whereas it's going to cause pea soup diarrhea, which is this is what it is mentioned into literature. I really don't want to spoil soups too, but it is how it is. Pea soup, stools, diarrhea, watery diarrhea basically, yeah. And this is going to cause bloody diarrhea. Also now people are going to have this out bloody diarrhea is also associated with Shigella. Yeah, it is associated with Shigella, but Campylobacter jejuni are like a rarer cause, but it's an important one because we're discussing GBS. And the another one, curved rod, we could differentiate on the basis of urease positive, which is H. pylori. H. pylori is quite famous, It is associated with PUD, peptic ulcer disease. It colonizes into the antrum of stomach here and causes peptic ulcer disease. So also, we call this as triple positive. So why triple positive? Because it is oxidase positive, catalase positive, also it's urease positive. So this way H. pylori is triple positive. Okay, this is the micro part. Let's leave it. There's other question. Let's talk more about Campylobacter jejuni first. So we talked about it, how it is seen in summers because it grows in 42 degrees Celsius. It affects mostly children and young adults, and the shape and size, everything. So how Campylobacter jejuni is transmitted? It is fecal-orally transmitted through person-to-person contact via ingestion of undercooked food or poultry, meat, anything, or unpasteurized milk. Let me write it down. By contaminated or undercooked meat, poultry, and even unpasteurized milk. So the this Campylobacter jejuni is antecedent cause for GBS, right? The another thing which is very specific with it is reactive arthritis. So if a person comes with you with some sort of GI infections and later it presents to you with ascending paralysis, you're going to think of Campylobacter jejuni. But if the patient is going to come to you with some sort of infections, GI infections 2 or 3 weeks earlier, and then now he's complaining of arthritis, joint pains, then you're going to think of Campylobacter jejuni. Okay, so this was one cause. The other causes are like CMV, CMV, EBV, mycoplasma pneumoniae, or even in very rare conditions after vaccination from influenza. However, this isn't the case in Pune. So in Pune, the outbreak of GBS is due to the contaminated food. In India, we don't do the regular vaccination of influenza. Like influenza vaccination is only recommended in elderlies or in the young babies going to endemic zone. It's not a cause here right now. And also earlier in like 1924s, back then there were also old strains of rabies also used to cause this. So this is all about the infection part. So we go to the pathogenesis. Pathogenesis, we have mentioned it like multiple times. It is autoimmune condition. So what exactly autoimmune we're talking about? So it's an immune response to non-self antigens like Campylobacter jejuni. So let me use a short form. Campylobacter jejuni. So immune response to the non-self antigens that get misdirected to the self or host nerve tissue. So this phenomenon is something that we are forming antibodies against the microbe, and that antibody has some sort of common resemblance to an epitope present on our self nerve tissue, which is harming it, cross-firing on it. So this particular mechanism is known as molecular mimicry. So the epitope mentioned over here over our nerve tissues are basically gangliocytes. So these gangliocytes are present on our nerves, and this serves as the epitope for this molecular mimicry. So the antibodies we form go and react on this gangliocytes as anti-gangliocyte antibodies, right? On the basis of this antibodies, we divide GBS into certain subtypes. It's mentioned over here. This is the table from Harrison. So the subtypes are the most common. Let me write it over here. It's the most common type of GBS, which is acute inflammatory demyelinating polyneuropathy. So the name is self-explanatory. It is a demyelinating condition and it's an acute one. All the GBS are like acute one. So this antibody over here is like quite important, associated with anti-GM1 antibody. So it affects adults, are affected most. And in diagnosis, we can use electrodiagnostic tests, or also even CSF examinations are also available. So here when you do the electrodiagnosis, you see there is a demyelinating problem. The antibodies first act on Schwann cell surface and then widespread on myelin damage and macrophage activation. Okay, we won't read this, it is like too long, but let's just get to the crux. The most common is AIDP. The next one is Aman. I call it as Aman. And the next is Amsan. Then the very important one, MFS, Miller-Fisher syndrome. So these are the subtypes of GBS. Let's learn the antibodies. AIDP, most common, associated with anti-GM1 antibody. Aman has an M in itself, right? So it is not, this is a cross mnemonic, okay? M here goes with this one. So Aman is not going to have this anti-GM1 antibodies. You could confuse it likewise. And this demyelinating over here goes to this one. So anti-GD1 antibody. So this is sort of cross mnemonic. AIDP and Aman are sorted for us. Amsan doesn't have a very specific antibody for itself. So let's leave Amsan. Amsan is going to have an extra sensory involvement. Otherwise, it is very similar to Aman. Then the third one is Miller-Fisher syndrome. Like the syndrome is itself very important, and the antibody associated with it is anti-GQ1B antibody. So this Q and this Miller-Fisher syndrome is like a great question to ask in entrance exam. So we are going to remember this way. So these are the four variants of Guillain-Barre syndrome. So here we talked about the subtypes of GBS. Let me show you a picture from Harrison about this pathogenesis. You could visualize it nicely then. So this one is the demyelinating one. You could see there is axon, the covering myelin. It is getting attacked by this macrophage as a result of complement activation, right? So it is going to activate macrophage, and this is going to damage the myelin part of this neuron, and therefore it is AIDP, acute inflammatory demyelinating polydent. So this way we can say, you can see this, right? This is the axon, this is the myelin covering, antibody binds to the antigens, and these antibodies are which one? Anti-GM1 antibodies, right? So these antibodies are going to bind to this epitopes, which are gangliosides over this myelin, and going to cause complement activation. This is MAC, membrane attacking complex, which is going to cause the actual injury by macrophage scavenge. And this is how you could see the most common type of Guillain-Barre syndrome subtype, AIDP. The next one is the second type of damage done in cases of Guillain-Barre syndrome, which is motor axonal cases, like our Aman, Amsan, which are actually motor involvement due to the axonal damage. So here we could see the okay, this cross section is better. This one is the axon, it's covering as myelin, and here comes our macrophage, which is going to damage this axon. So this one is the axonal part. So you can see this GM1, GD1 antibodies over here. So let me clarify, this GM1 is the most common antibody associated with AIDP. Yeah, I agree with that, but some sort of the titer is also GM1 in case of Aman and Amsam. It's not only GD1. Okay, it's not specific, but it is the most common, the increased titer in Aman and Amsam, but you could also find GM1, so you're not getting confused by this part. So this antibodies attach to the epitopes, which are our gangliosides, over this axonal part. You can see this, right? There is no myelin covering over here, and then they're going to activate this our membrane attack complex, and then macrophage is going to somehow sweep in, and then it is going to damage this whole axon. The myelin covering is still very healthy. So this small box down there, you could see this one is axonal involvement. So axon over here, this is the paranode node, and then we have nodes of Ranvi's. Okay, so this axonal and nodal one are basically most commonly going to affect this nodes of Ranvi's, and this node, paranode are the sites where they exactly act. So this is a pictorial representation which could help you understand. I hope I made myself clear over here. I really tried hard to explain it. Hope it helps. Otherwise, it is not very important. You know the antibodies, you know the type. One is demyelinating, the other two are axonal, and the last one, which is Miller-Fisher syndrome, is actually a mix. So let me give you a mnemonic for Miller-Fisher syndrome. I have remembered it as OAA. What is OAA? OAA is ophthalmoplegia, ataxia, and areflexia. So these are the three things which are going to be prominent in this condition. And when you talk about anti-GQ1 antibody, it is associated with Miller-Fisher syndrome, because Miller-Fisher syndrome has this unique property of ophthalmoplegia. This antibody is directly correlated with ophthalmoplegia. So even if it is not a Miller-Fisher syndrome, if you see GQ1 antibody titers increased over there, then it is somehow going to involve our ocular, extraocular muscles, which we have written over here, ophthalmoplegia. So unlike other GBS, in Miller-Fisher syndrome, there is, we have symptoms over here, a good chart of it. Yeah. So let's pinpoint the difference between GBS and Miller-Fisher syndrome. So GBS, we have read bilateral and flaccid weakness of the limbs. It starts with the lower limbs and then it progresses. Decreased or absent DTRs. Then it is a monophasic illness, which Their onset and nadir is in between 12 hours to 28 days. And electrophysiological findings of GBS, we will discuss it, is going to show prolonged F latencies, and the amplitude of muscle action potential are decreased. And also on CSF examination, there is cytoalbuminic dissociation. We'll talk about it in detail further. And there is absence of alternative diagnosis of the weakness. These are like GBS symptoms. Okay, when we go to Miller-Fisher syndrome, you could see there is bilateral ophthalmoplegia, OAA, and then there is ataxia, and this is areflexia, absent DTRs. But the striking difference is there is absence of limb weakness. So in Miller-Fisher syndrome, there is no limb weakness. It is also monophasic illness in between 12 hours to 28 days. Cytoalbuminic dissociation, nerve conduction studies here is also quite important. So these are, let me highlight the differences. Nerve conduction tests over here are normal or indicate involvement of sensory nerves. This is different from GBS. And there is no consciousness, the consciousness is held, and there is no involvement of corticospinal tract. So this is the difference between Miller-Fisher syndrome and Guillain-Barre syndrome. I think I have explained it well. So this is a chart you could go through. That basically level 1, level 2 and level 3. In level 3, we don't do CSF examination. You didn't get the time to do CSF examination, or the patient has reached the plateau phase. And then, see, it is a monophasic disease, okay? So initially in 12 hours, it would start and progress from legs to knees to hips and then chest. And this could take like 7 days or 3 days, depending on the individual patient. It is not going to be same for everyone. And then later, at some point, the patient is going to plateau. The symptoms won't increase. Symptoms are going to be the very same, and they are just conservatively managed. So in plateau phase, you are not going to do the CSF examination. You know that it is Guillain-Barre syndrome, but before that, in the early part of the presentation of a patient, like he's complaining just paresthesias or just limb weakness, and you just suspected it could be Guillain-Barre syndrome, so you would do a CSF tap, right? And then you would examine it. So that's all that is written over here, like in level 3 diagnosis certainty, when you don't even have CSF. So they have all the same points, you can read it. And similar goes for Miller-Fisher syndrome. So here's lab finding. What I have written is albuminocytological dissociation. Albuminocytological dissociation. It is actually when you do a CSF examination, this is the fluid which you get. They are going to show increased protein levels of around 100 to 1000 milligram per deciliter, which is certainly increased level of protein without any pleocytosis in CSF. So you're going to see increased glucose level, but there is no cells, which we call as albuminocytological dissociation, which is very suggestive of GBS. You are not going to find this scenario in anywhere else. Let's give in another condition where you would have increased proteins, increased polymorphonuclear cells, which is neutrophils basically, with decreased sugar content and increased ICP. So this is suggestive of bacterial meningitis. So this is off topic, but it is also important. When you see CSF questions, you are going to need this. Bacterial meningitis. But if there is increased protein, increased lymphocytes, certainly normal sugar or a normal level of intracranial pressure, then it is suggestive of viral meningitis. But when you see increased protein, increased lymphocytes, but a slight decreased amount of sugar and a slightly raised ICP, this is suggestive of fungal meningitis. So this is off topic, but it is very important. It could give you a question. When you are asked to examine CSF, you would see these certain values. I would recommend you to see the normal values of sugar and protein. If they go to an extent where they mention figures, then you have to know about this. The other lab findings which we see is in nerve function test. As I mentioned you, there is prolonged F latencies and a decreased amplitude of muscle action potential. We call it as CMAP. Yeah. So these two are the electrodiagnostic tests we could do, but in general, in practice, we don't actually do it. Like, could make a diagnosis of Guillain-Barre syndrome just by its symptoms and the history of infection. So, and these two are very typical for AIDP. Okay, so whenever I mention something about GBS, you should understand that I am talking about AIDP because it's the most common type. And Miller-Fisher syndrome is quite different from GBS, but we have discussed in details regarding the antibodies to the presenting symptoms, everything, right? The next part is treatment. So this comes to an end. In part of treatment, like I mentioned, if you suspect that the patient is having GBS, so you won't wait for your results to come for the CSF examination or electrodiagnostic tests. Okay, this is what it is mentioned over here. We directly start with the treatment. What is the treatment? Okay, treatment over here is high dose intravenous immunoglobulins at a rate of 2 gram per kg of body weight. Okay, and this should be given in a day because it's an acute condition. You have to act very fast. The other option we have is plasmapheresis, which is basically plasma exchange. So this comes with an increased risk of infection. If you think logically, you would never go for plasma exchange because in this you have to ask the patient to be there in hospital and you would draw blood out of him and then you would do plasma exchange. This is too much. So feasible logically, you could, if they ask like which is the most reliable treatment you would go for, it is IVIG because you just give the infusion and then you leave the patient because it's easy and also less invasive. And in a meta-analysis it has shown that the IVIG has a better prognosis with treatment, right? So this was all about Guillain-Barre syndrome. But yeah, there is another point that you would never use steroids for treatment of Guillain-Barre syndrome. Never. This was all about Guillain-Barre syndrome. So yeah, we're done. Okay, there is another thing which we would discuss. It's a very short topic. Let me finish it in 2 minutes. There's another variant. It's not a variant, it's a type of, it's something which is very similar to GBS. We call it as CIDP, which is chronic inflammatory demyelinating polyneuropathy. So this is distinguished from GBS because as the name itself suggests, it's a chronic condition. GBS is an acute condition which shows symptoms within 12 hours to 28 days. This over here is a chronic cause which could show symptoms even till 90 to 98 days, which is nearly about 3 months. So therefore it's a chronic condition. It's all the CIDP onset, you could say it's a gradual one and progresses over months. But otherwise it is very similar to GBS, be it's like ascending. It is also ascending paralysis. On CSF you would also see Here also you would see albumino, cytological dissociation, and the nerve conduction tests, nerve function tests are also similar. So basically it is exactly something like GBS, but it's onset and the symptoms are very chronic. It progresses over months, like months to 3 months. So the treatment part is also very similar. It is IVIG, very much preferred one at the same rate, but it is given over 2 to 5 days, and this 2 to 5 days treatment is going to happen for like next 3 months. Chronic disease, so chronic treatment. So for the next 3 months you're going to do this, and the next option is plasmapheresis. But unlike GBS, here comes the role of glucocorticoids. You could use glucocorticoids like 60 to 80 milligram of prednisone per oral every day, daily, for 2 months. So even if the patient is not going to respond, then you could go for other line of drugs, which is immunosuppressive drugs, as thiopurine, methotrexate, cyclosporine, cyclophosphamide. Even we could try rituximab, which is anti-CD20, and your patient is still not responding. Then then you should examine your patient. You should evaluate your patient for POEMS. What is POEMS? POEMS basically is polyneuropathy, organomegaly, endocrinopathy, M for monoclonal gammopathy, and the last is for skin changes. So this was about POEMS. I won't get into details. Already this video is quite lengthy enough. So yeah, this is pretty much everything you're going to need for your GBS, and this is all given in Harrison's. I don't think there is anything more you need to know about GBS. So now I could conclude this video. But yes, if you find this video useful in any way, then please like, share and subscribe to the channel. It would really motivate me to post more such high yielding videos, and I'm open to suggestions. If you want to suggest any topic which you want me to revise for you, then I will be happy to help. Thank you.